Welcome to the Concierge Care Health System podcast. The information shared in this podcast is for general informational purposes only and does not constitute medical advice. Listeners should be aware the content is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a physician or other qualified healthcare provider for medical questions.
Welcome back to the Deep Dive. Today we're diving into something huge, a global health challenge that probably feels familiar, the obesity pandemic. We hear about it all the time.
We do. The rising numbers, the health risks.
Yeah.
It's constant news.
Exactly. But here's where it gets really interesting, maybe even a bit unsettling. There's a critical aspect of this crisis, often overlooked, that kind of turns our usual understanding of health and body weight on its head.
We're talking about what some call the Asian anomaly when it comes to obesity. It's a real paradox.
A paradox. How so?
Well, you look at the standard international numbers, and many Asian nations historically show lower rates of obesity. Seems good, right?
Yeah, you'd think so.
But, and this is the crucial part, they simultaneously face a much higher burden of serious chronic diseases. Think type 2 diabetes, heart disease.
Yeah.
The numbers are disproportionately high.
Wow. Okay. Lower obesity stats, but higher rates of related diseases. That is baffling.
So what's our mission today in this deep dive? What are we trying to figure out for you, our listeners? Our mission really is to unpack why. Why is the standard, mostly Western developed way of diagnosing and managing obesity, well, kind of failing when we applied it to people of Asian descent?
Okay.
We'll dig into the unique physiology, the genetics, the environment, even cultural factors. We'll look at what has worked in some places and shine a light on the systemic issues that create this hidden pandemic.
A hidden pandemic. I like that framing.
Yeah. And by the end, hopefully you'll have the insights to see past those surface level statistics. You'll get a better feel for the nuances of health risk, not just in Asia, but really in diverse populations everywhere.
All right, let's get into that core mystery then. Lower numbers, higher risk. How does that even happen? I mean, globally, obesity is massive. The WHO said, back in 2022? 43% of adults overweight, 16% obese worldwide. Huge numbers.
Huge. And climbing steeply since the 90s. But then you look at Asia, and the numbers seem deceptive.
Deceptive how?
Well, take Vietnam, for instance. Their reported obesity rate is tiny, like 1.7%. India, maybe 1.9%. Compare that to the U.S. at 33%.
So on paper, it looks like they're doing great.
Exactly. Looks like a success story almost. But that's where the alarming reality kicks in. Those stats are misleading because the risk associated with a certain body weight is different.
Yeah.
Meaning the mortality risk, the chance of dying from related conditions for a given body mass index or BMI is actually higher for Asians compared to Westerners.
Okay, that's critical.
Think about China. It now has the world's largest population of people with diabetes. The rate of diabetes there has nearly quadrupled in just 15 years or so.
Quadrupled, despite those lower obesity numbers.
Precisely. It shows the tools we're using, the standard BMI cutoffs, they're just not capturing the true risk profile. It's not just about rising rates overall. It's about a fundamental difference in how body fat and metabolic health connect in these populations.
Which creates that hidden pandemic you mentioned, a pandemic of cardiometabolic risk, heart attacks, strokes, diabetes, that the standard numbers just don't show.
You got it. It's lurking beneath the surface.
So this brings us straight to BMI. It's the standard measure, but clearly it's failing here. Why? Where did BMI even come from?
That's the root of the problem, really.
Yeah.
BMI, weight in kilos divided by height in meters squared, was mainly developed based on studies of European populations, white men mostly, historically.
Oh, okay. So it wasn't exactly designed with global diversity in mind.
Not at all. So when you take those universal thresholds like BMI 25 for overweight, 30 for obesity, and apply them across the board, particularly to Asian populations, you systematically underestimate the actual health risks. Lots of people who are genuinely at risk get missed.
That feels like a huge blind spot.
Right.
What are the specific physiological differences then? This Asian phenotype you mentioned earlier.
Right, the Asian phenotype. There are a couple of key things. First, for any given BMI level, people of Asian descent tend to have a higher percentage of total body fat, usually around 3 to 5 percentage points higher than Caucasians at the same BMI.
So two people can have the exact same BMI, say 24, which is considered normal.
But the person of Asian descent might be carrying significantly more body fat, proportionally. Their body composition is just different, even if the scale reads the same.
That's a major difference. And how often is that overlooked?
Way too often.
Yeah.
And maybe even more important is where that fat is stored. Asians tend to accumulate more visceral adiposity, VAT. That's the dangerous fat deep inside around the organs.
The metabolically active fat, right, the one that
Mhm.
really drives disease risk.
Exactly. They have this propensity for visceral fat even at lower overall body weights. This leads to central obesity, sometimes called the skinny fat paradox. You might not look overweight, but you have this harmful fat internally.
Research backs this up.
Oh, definitely. Studies consistently show, for example, Chinese and South Asians having significantly more VAT than Europeans, even when you control for BMI and total body fat. So it's not just how much fat, but where it is. That location is key for Asians.
A crucial distinction. And I think you mentioned lean mass differences too.
Yes, that's another piece. Some groups, particularly South Asians, might also have lower lean body mass, less muscle and bone for a given amount of body fat.
So higher body fat, more of the dangerous visceral fat, and potentially less muscle mass.
It all combines to create a more vulnerable metabolic profile. The risk just escalates much faster at lower overall weights.
Which means, logically, tons of people who are labeled normal or healthy by standard BMI are actually walking around with elevated risk for diabetes, heart disease, and they probably don't even know it. The system is failing them.
It is. It's a systemic issue.
So how do we fix this measurement problem? What should we be using instead?
Well, the good news is that expert bodies, internationally and nationally, have recognized this. There's a strong call for revised diagnostic criteria, specifically for Asian populations.
Okay, like what? Different BMI numbers.
Exactly. The most commonly cited alternative cutoffs suggest lowering the threshold. So overweight would start at a BMI of 23 or higher, and obesity would start at 25 or higher. Some even suggest 27.5 for obesity in certain contexts.
Have countries actually adopted these?
Many have, yes. Countries like Korea, India, China, they've incorporated similar lower thresholds into their national guidelines because they see the risk profile is different for their populations.
Okay, so lower BMI cutoffs, but you mentioned the location of fat being so important, especially that central visceral fat. Is BMI even the best tool then?
That's a great point. And no, it's often not the best predictor for this group. Measures of abdominal fat, like waist circumference, are actually much better at predicting cardiometabolic risk in Asians.
Because that gets at the central obesity issue directly.
Precisely. And there are Asia-specific cutoffs recommended for waist circumference too, 90 centimeters or more for men, and 80 centimeters or more for women. Measuring the waist is crucial.
So let's translate this for the listener. If you're of Asian descent, what does this mean when you go to the doctor? What should you be aware of or even ask about?
It means you and your doctor need to think differently. A BMI of 24, which sounds fine by Western standards, should probably be classified as overweight for an Asian individual.
And that should trigger.
It should trigger proactive screening. Screening for type 2 diabetes, high blood pressure, unhealthy cholesterol levels, dyslipidemia. You need to catch these things early.
So as a patient, you might need to advocate for yourself. Ask if they're using these Asia-specific guidelines.
Absolutely. Ask the question. Because using these lower thresholds, using waist circumference that allows for much earlier detection and intervention, sticking to the old standards is, frankly, contributing to health inequity.
It really sounds like a perfect storm of factors driving this higher risk profile. You mentioned genes, environment, culture. It's all interacting.
That's exactly it. It's not just one thing. It's the convergence of these forces. Genetically, there's the thrifty gene idea.
Right, the theory that populations facing famine evolved to store energy really efficiently.
Yes, proposed by James Neal way back in '62. Think about South Asia estimates suggest nearly 90 major famines over 2,500 years. Genes that help people survive by storing fat efficiently would have been selected for.
But now, in a world with plenty of food, those same genes become a disadvantage.
Exactly. What was once a survival advantage becomes a liability. Those genes make people more prone to rapid weight gain and insulin resistance when calories are abundant.
And it's not just a general theory, right? Modern genetics has found specific things.
Oh, yeah. We've identified specific gene variants, like variants in the FTO gene, which are known to increase obesity risk in general, but might have specific impacts in Asians. And even more specific things are popping up. Like variants in a gene called DRD2 linked to craving starchy foods in Indian Malaysians. Or another gene combo, PRDM6-CEP120, found in Japanese people that seems to influence waist circumference directly related to that central fat storage in a way not seen in Europeans. So the genetic controls themselves seem somewhat distinct.
Okay, so genetics provides sort of predisposition, but then the environment must play a huge role in triggering that predisposition. What about the big societal changes in Asia?
Absolutely critical. We talk about the nutrition transition. A massive shift away from traditional diets, which were often plant-based and lower in fat.
Towards more Western-style eating.
Yes, high in refined sugars, unhealthy fats, salt, and especially ultra-processed foods, or UPFs. This is driven by economic growth globalization.
And I imagine big food companies play a role.
A huge role. Transnational food corporations, or TFBCs, see rapidly growing Asian markets as prime targets. They use very aggressive marketing, they influence what's available in stores, and they push these cheap, tasty, but often nutritionally poor, ultra-processed foods. The whole food environment changes.
And it's not just food, it's lifestyle too, right? Urbanization.
Definitely. People move from rural areas to cities. Work becomes less physically demanding, more sedentary. People rely more on cars or buses instead of walking. Leisure time might involve more screens than activity.
Plus, cities usually mean easier access to fast food and convenience foods.
Right. It all adds up to a much less active, more obesogenic, obesity-promoting environment.
Okay, so genes and environment. What about the third piece, cultural and behavioral factors?
This is really significant, too. Think about the erosion of those traditional diets. The Japanese washoku diet, for example. Plant-focused, small portions, umami flavors. It's historically seen as protective against obesity. As that gets replaced by faster, more processed options, you lose a powerful cultural defense.
And activity levels, are they dropping?
Sharply. In many Asian countries, over 40% of adults don't get enough physical activity. There's often a big gap between urban and rural areas, too. City dwellers tend to be much less active. Barriers include things like lack of safe parks or sidewalks, long working hours, maybe even cultural norms around exercise.
Then there's the perception of body weight itself. You said earlier it's complex, even contradictory.
It really is. On one hand, in some cultures, a bit of plumpness, especially in children, was traditionally seen as a sign of health, of prosperity. So you might have parents or grandparents encouraging kids to eat more.
I think I read a stat about that in China.
Yeah, a striking study found something like 72% of Chinese mothers misclassify their overweight children as being normal weight or even underweight. That traditional view persists.
But then clashing with that,
You have the immense pressure from globalized media pushing this often very thin, westernized beauty ideal, especially in East Asia, but elsewhere too. This creates a huge conflict, particularly for women.
trying to navigate those completely opposite expectations must be incredibly difficult.
Extremely. Especially for women in diaspora communities, living between cultures. It can lead to a lot of body dissatisfaction, stress, sometimes even disordered eating patterns. It's a tough balancing act.
So you put all that together, the genes, the obesogenic environment, the cultural shifts, and the health consequences start showing up, right? And crucially, they show up at lower BMIs.
That's the key takeaway. The risk for serious comorbidities, other diseases alongside obesity, kicks in much earlier for Asians. That visceral fat is just so metabolically damaging, driving inflammation and insulin resistance, even when someone isn't obese by Western standards.
Let's talk specifics. Type 2 diabetes seems like the poster child for this issue.
It really is. The link is undeniable and incredibly strong. Asians face a significantly higher risk of diabetes, even in the BMI range of 23 to 27.5. Again, that's normal or just overweight for other groups.
Which explains why countries like China and Malaysia have seen such explosions in diabetes rates.
Exactly. And South Asians seem particularly susceptible genetically. But it's not just diabetes.
What a
It's
close-up.
cardiovascular disease. That central fat is a stronger predictor than overall BMI for high blood pressure and heart disease in Asians. They also have high rates of metabolic syndrome, that dangerous cluster of risk factors.
And liver disease.
Non-alcoholic fatty liver disease, NAFLD. Very common, again, linked to that fat accumulating where it shouldn't, like in the liver. And several types of cancer, too. Colorectal, liver, pancreatic, breast cancer, after menopause. The risk is elevated. Studies in Korea, for example, have shown clear links.
Okay, this next idea is fascinating, but also a bit worrying. Metabolically healthy obesity, or MHO. How can someone be obese but metabolically healthy?
It's a recognized category, yes. Someone might meet the criteria for obesity based on BMI, but their blood pressure, blood sugar, cholesterol levels might still be within the normal range at that point in time.
But you said at that point in time quite deliberately there.
I did. Because the crucial thing for our listeners to understand, especially regarding Asian populations, is that MHO is often not a stable long-term state. It's more like a ticking time bomb.
Not a safe place to be then. It gives a false sense of security.
It definitely can. It might delay people from making important lifestyle changes. because research, longitudinal studies that follow people over time, shows that a large proportion of individuals with MHO eventually transition to being metabolically unhealthy.
And what triggers that transition?
That visceral fat accumulation seems to be a key predictor. As people age, even if they were MHO earlier, that internal fat keeps having effects, and eventually the metabolic systems get overwhelmed. This is a massive concern for Asian countries with rapidly aging populations. Today's middle-aged MHO cohort could become tomorrow's huge healthcare burden.
Beyond the purely physical diseases, what about the psychological and social toll? You mentioned the conflicting pressures.
The toll is huge. Weightism. The stigma and discrimination based on weight is incredibly common in many Asian societies. It's sometimes seen as one of the last acceptable forms of bias.
How does that manifest?
Stereotypes, negative comments, sometimes even affecting job prospects or social interactions. And again, it intersects with those complex beauty standards, creating internal struggles, body dissatisfaction, anxiety. It can make the whole journey of trying to manage weight feel very isolating and challenging.
Okay, so the problem is complex and multi-layered. But are there solutions? What interventions have actually worked? Are any countries getting things right?
Yes, there are definitely lessons to be learned. Some countries have implemented really impressive national strategies. Japan is often highlighted. They have one of the lowest obesity rates globally, and it seems to be down to a really integrated prevention-first approach. They actively promote their traditional washoku diet. They have national health plans like Health Japan 21 setting targets. There's a law, shokuku, mandating nutrition education and ensuring high standards for school lunches.
Wow.
Plus, things like a strong walk-to-school culture helps keep kids active. And adults aged 40-74 get mandatory annual checkups, specifically looking for metabolic syndrome. It's systemic.
That sounds incredibly comprehensive. Any others? Singapore?
Singapore declared a war on diabetes back in 2016 as a major national effort. They use things like a healthier choice symbol on food packaging. They work with food courts to offer healthier meals. They have mandatory Nutrigrade labels on drinks showing sugar levels.
So making healthy choices easier.
Exactly. And they even banned partially hydrogenated oils, a source of trans fats.
What about South Korea?
South Korea also has a strong, comprehensive plan. They use those Asia-specific BMI and waist cutoffs in their clinical guidelines. Importantly, their national health insurance actually covers bariatric surgery for severe obesity, which increases access to effective treatment. And they have laws protecting children, like restricting junk food advertising and using clear, color-coded nutrition labels.
Looking at these examples, Japan, Singapore, South Korea, the big takeaway seems to be this systems thinking, right? It's not just telling individuals to eat less and move more.
Absolutely. It's about creating a health-promoting ecosystem. Government, industry, schools, communities, everyone has a role in making the healthy choice the easier choice. It shows obesity isn't just a health sector problem. It requires a whole-of-society response.
So that's top-down. What about bottom-up approaches, especially for those Asian diaspora communities living in, say, the UK or the US? How do you reach them effectively?
That's crucial because mainstream health systems often don't cater well to their specific needs or cultural contexts. Culturally resonant communication is key. Things like the Apkai Dietitian Facebook group for British South Asians. It shares healthy versions of traditional recipes, tackles myths in a culturally relevant way. Or studies like Beaches, which worked within UK primary schools that had mostly South Asian students. You have to go where people are.
And tackling the stigma we talked about must be important too.
Very. For instance, when setting up support groups for South Asian Muslim women, researchers found that framing it around wellness rather than obesity made people much more comfortable participating.
That makes sense.
And leveraging trusted networks is vital, using mosques, temples, community centers, ethnic grocery stores, local radio, even WhatsApp groups for outreach. The core message is, cultural competency isn't just a nice-to-have, it's essential for these interventions to actually work.
Okay, so there are promising strategies, both top-down and bottom-up, but clearly challenges remain. What are the biggest hurdles we still need to overcome?
Well, the most fundamental one is still persistent underdiagnosis. As long as clinicians in many places stick to the standard Western BMI cutoffs, they're going to keep missing people who are at high risk.
So awareness and adoption of the right metrics is still lacking.
Yes. And then there's access to treatment. Newer, more effective anti-obesity drugs and bariatric surgery are often expensive or just not available in many parts of Asia or for lower-income diaspora groups.
What about health literacy? Do people understand these specific risks?
There are definite gaps. not just among the public, but sometimes even among healthcare providers who might not be fully aware of the Asian-specific guidelines. You mentioned that study in China where appearance was prioritized over health that indicates a need for better education about the actual health consequences.
And finally, policy. Getting governments to act.
That's often the toughest nut to crack. Policy inertia. Many governments hesitate to implement the really bold structural changes needed, things like significant taxes on sugary drinks, real restrictions on marketing unhealthy foods, especially to kids. Without that strong government action to reshape the environment, just focusing on individual behavior change is unlikely to turn the tide at a population level.
This has been incredibly insightful. This deep dive really shows how the standard way of thinking about obesity, mostly developed in the West, just doesn't fit the reality for billions of people of Asian descent. It's masking a huge silent health crisis.
It truly is. The unique Asian phenotype with its different fat distribution and metabolic consequences demands a fundamental shift in our approach.
So the takeaways seem clear. We need widespread adoption of those Asia-specific screening guidelines, the lower BMI cutoffs, the waist circumference measurements.
Absolutely. Plus, better education for doctors and nurses, policies that actually change the food environment, urban planning that makes it easier to be active, and efforts to preserve healthier traditional diets. It's a global issue that needs a globally nuanced response.
And hopefully what you, the listener, have gained today is a deeper understanding that medical standards aren't always universal. This conversation gives you that critical lens to look at health data and health advice more carefully.
And maybe it leaves you with a provocative thought to ponder. If our understanding of something as major as the global obesity crisis can be so fundamentally flawed for billions of people simply because we use the wrong yardstick and assumptions, well, what other widely accepted universal truths in science and society, maybe even in our own lives, might be masking critical risks or preventing fair solutions for specific groups of people?
That's a powerful question to end on, something to definitely think about as we navigate our complex world. Thank you so much for sharing your expertise today.
My pleasure.
And thank you for joining us for this deep dive. We'll see you next time.
Concierge Care, providing world-class, personalized care for patients and members, taking a proactive approach by offering its free digital health clinic for anyone in need of these services. Reach out to us via our website, www.health.conciergecare.net, or give us a phone call at 786-809-2345.